my background is I'm a retired GP. I was working in inner city Leeds for over 30 years. I had a great career. I was a Leeds United doctor for 12 years. And basically, when I retired, it was when I decided I needed more to do. I didn't want to stay in the NHS anymore, but I really like people. So I started working with different charities, and then basically I met a representative of Yorkshire Cancer Community as an event, and she rang me up and said, "Would you like to join our charity?" So I started as a trustee. I'd only been there 3 months and the chairman left. I don't think it was anything to do with me. So I became chairman. So Yorkshire Cancer Community, we're a group of people. We're funded by the West Yorkshire and Harrogate Cancer Alliance. We're going to give a talk called Cancer Smart. And Cancer Smart is a basic talk that we give to people. It talks about healthy living, but more importantly, it encourages people to follow up, to go and have their smears, their poo tests, their mammograms. But more importantly, we talk about it educating people to know their own body. And it's quite simple, isn't it? So, if you have a lump in your breast or you have blood in your poo, something's wrong. But you can get all sorts of vague symptoms that can relate to having an underlying cancer. So it's telling people basically to actually go and, if they've got something wrong, go and see the doctor. Be very, very specific in your symptoms. Go and see a doctor and say, don't say I'm constipated and I've lost weight. It's I'm going once a week instead of every day, and I've lost a stone since Christmas. We were taught psychiatry at medical school, but it was very complex problems. Through my years of working, my family has a very strong history of mental health problems. So my mother had a breakdown, my brother did. And as you know my story, I was at work, I was struggling because my mum was terminally ill. When you can't make a patient better, it's bad. When it's your own mother, it's terrible. And I went into work one day and I just stared at the patient for 2 hours, and then I thought, go home, Stuart. Went home, I spent 4 months at home with severe anxiety and depression. I never went out the door. I didn't speak to anybody for weeks, and this is me now who speaks to everybody all day long. And it carried on, and my mum was at home, and we had care for her because she had dementia and breast cancer, and she ended up in hospital. And then the hospital rang me one day and said, "Dr. Manning, we can't do any more for your mother." I went down to the hospital, I held her hand, she went to sleep peacefully. My head started to clear, and 2 weeks later I went back to work. Just kind of my epiphany. When you talk about mental health, if you look at mental health and cancer, it's a double-edged sword. So we're now seeing more and more people with dementia who have cancer because we've got an aging population. So you're looking at not just the effects that cancer has on somebody with an existing medical problem, psychiatric problem, but the effect that people can react to cancer in a way that causes them anxiety and depression. You may be young, you've got a young family, and suddenly you've got all the treatment to go through. And although cancer survival is much better, quite a lot of people do still pass away from cancer. Some of the people I work with, are women in their 30s and 40s that I've come across the different charities I work for, who are planning, trying to plan the life for children and things where they won't be there. It's very, very difficult. Over a period of time, people have become more aware of mental health problems, but not just depression and anxiety, but, all the things like ADHD and also autism. And it's terrible because the wait to get on schemes or treatment or talks can be years, particularly for older adults. So it's a problem that isn't particularly well tackled, but it works both ways, which is why it's very important when people are diagnosed with cancer that they have something called prehab. So this is some work that's been done by Macmillan, and what they do is they talk to people and they try and get people to exercise and eat healthy, but also look for psychological problems. The only difficulty with that is it depends how long you've got between the diagnosis and the treatment. And obviously some treatments need to be undertaken almost immediately. If you've got a tumour that's blocking, or you have to have it removed. But prehab works and exercise works, and also supportive people. So basically, cancer nurse specialists, somebody you can engage with. So, and particularly if you know somebody's family history, if GPs know it, but as a GP, you need to make it clear when you refer people, although it's not directly relevant, that this person has previously suffered from depression or they have a family history. So you can tackle it at the beginning. Because once people start the treatment pathway, it's often very difficult to basically do something that's going to alter things. If people go through the treatment, they're worried about the future. There's loss of earnings at work. There are some very good organisations that deal with not so much mental health problems, but getting people together at the end of treatment. When people have cancer treatment and they get to the end of it,
yeah,
they ring the bell, and all the relatives and friends think they're cured, but they're not. And the other thing that I have come across, which is really difficult to do, is survivor guilt. So basically, you're in a group of people. You've had your mastectomy, you've had your radiotherapy, your chemo, and that may take a year, but you've lost some of the people along the way. So there's an organisation called Cancer Support UK, which is one way of going to get it looked at, where they have groups of people online, 6 at a time, and they do 6 sessions where they try and get people to support each other. And Macmillan do a similar thing. So it's really monitoring people, and it's very, very important that people have this holistic health assessment, holistic care assessment at the beginning. So you know exactly what you're dealing with, because you get all this information about a patient and the blood tests and the fact that they've got possible bowel cancer, but you need their history as well, so you can treat them holistically as a whole person. And I think sometimes hospital doctors, they do the surgery, they're interested in that, and you go home, but they don't know any further after that. So I would like it to be something that was pushed more in medical schools as well, and things, so that people understand what it's like. And the final way to tackle this sort of problem is to use lived experience.
Yeah.
So in our talks, we use lived experience, because the best person to tell you what it's like to have breast cancer surgery is somebody who's had it, and trying to spin it in a positive way. I mean, in the way that, there's different ways of looking at it. When people get a diagnosis, there's 2 arms to outcomes. So the outcome might be the survival rate, but it's also the quality of life. And I'm very, very keen on pushing that and trying to put some sort of positive spin if you can. So, if somebody says to me, I'm really upset, my grandmother's got end-stage breast cancer and she's got a 50% chance of living in 5 years, I would turn that around and say, okay, let's assume your grandmother is going to live for 5 years. What are we going to do? So it's tackling it at the different stages. And the earlier you tackle it and the earlier you can build up people's confidence, then I think the better their outcome. As you have more and more treatments, they're done in specialised centres. And I think the sort of problem you have is, I live in North Leeds. I've looked after people in Centre of Bexley, which is 15 minutes. But you can imagine that if you live in the wilds of North Yorkshire, it takes you 2 hours to get here, and then 2 hours to get back, and you feel lousy. But you've got that 2.5 hour journey building up what it's like, and that is difficult. And people, interestingly, a significant amount of people drop out of drug trials, because it's just they can't do it. It takes up so much of their life, and particularly when you look at something like radiotherapy. Radiotherapy, some treatments are every day for 6 weeks. So it really is difficult for people. And the other thing that I think we have to consider is enabling people to make the right choices. I always say, so I think that, going back to what I said about starting at the beginning, people need to know at the outset the different treatments. I think the best format is for people to be given the diagnosis, go home for a week, because once somebody says, I'm sorry, your wife's got cancer, or you don't hear anything, and then come back and see what their options are. I can't ever make decisions for people, but all I say to is, just think, put the doctors on the spot, and it's the same in terms of, there are different treatments that are less invasive. So say and people have to understand. I mean, if you are from a foreign country, don't speak English, and you have a learning disability, how the hell do you understand it all? So it's up to the doctors to try and explain that, you may go for, okay, so if you take something like prostate cancer, you can have surgery, you can have tablets, all sorts of things. It may be that taking a tablet a day is the best way forward for you, even though it may not give as much, as greater life expectancy. But, take the tablet. I mean, it's very, very, it is difficult. It is difficult. What they're looking at now, this is interesting, to try and help people. I mean, who are, who it isn't easy to engage with. Is there are schemes. There's a scheme somewhere in Yorkshire where they're doing ambulatory chemotherapy. So they take chemotherapy to the patient. So like, if you're somebody in a nursing home with dementia and other problems, some treatments cannot be given. You can't give radiotherapy at home, obviously, but some treatments can be. So you may go and try and give the treatment in the place where the patient is. So it's all of that, but it's actually getting people to understand. It's very difficult, and as I said, I had to make the decisions for my mother because she had dementia, and it's not great. You have to decide. So I think that's the way forward as well, is talking to patients and perhaps selecting the treatment that is less invasive and less disturbing of your life. And it's also, and one thing that actually just occurred to me, it may be that, if you can have your chemotherapy at home or drugs at home, you can carry on working, which is very, very important, because the treatments, if you have surgery and radiotherapy and it can be a year off work, and financially that can be crippling.
Yeah, and socially as well, I suppose.
And
it's you lose that connection with people, don't you?
Yeah, you do, yeah, and it's difficult to go back. I think sometimes the other thing, as I said, is going through treatment with people you become friendly with is positive in a lot of ways, except for the people who don't survive. But it's up to as time goes on and our treatments get better and our ways of delivering them get better, it's really up to the doctors, and I think not necessarily doctors, but the cancer nurse specialists. A lot of treatments you don't need to start tomorrow, but actually have a week or 2 weeks building up to it to assess what is the best thing for this patient. And it may be there's some studies where patients come into hospital once a week and they're given chemotherapy and then they're given radiotherapy because it's a combined thing and it's done on the same day. All these things and all these options will become more important in the future.